So to start with, just to go over what we've done across London and Manchester as part of the Vanguard programme. So we've taken a lead on a project as part of the Vanguard to develop metrics across London and Greater Manchester. So that's covering 4 out of 19 of the alliances nationally with a population of just over 11 million, and that's just over 20% of the population nationally. The approach we've followed, which has not always been everyone's approach in London, but the approach we followed is to use national data sources where possible to obtain that data, rather than, for example, creating data feeds from individual providers into separately. We've shared those metrics on a cloud with NHS stakeholders, which, so anyone in London or Manchester who works in the NHS, we've given access to that cloud with our outputs. So that's had over 6,000 downloads since it was launched a year and a half ago, with now over 400 users accessing the site. The areas covered in those metrics, just to summarise, they've split into 7 areas. First one, obviously, cancer waiting times, as you'd expect. The next one is data quality, which is key, I think, particularly around feeds into the cancer registry, but also other feeds nationally, because quite often some of the variation you see in other areas is because of data quality issues rather than actual variation in practice. Patient experience has been purely based on National Cancer Patient Experience Survey, because that's the one main source nationally. So as well as preparing comparable metrics, we've also, for example, produced a national league table, which Macmillan now stopped doing, but we've actually continued that on an ongoing basis. Also, an area on prevention, early diagnosis and diagnostics, so things like stage distribution, screening rates. Treatments, we've done quite a lot of work looking at HES, so looking at variation in things like minimal access surgery. Living with Beyond Cancer is the one area where we've had to rely on trust feeds. So we get trust feeds from across London now on a quarterly basis to try and record that, which isn't recorded elsewhere nationally. And then finally, a section on the latest incidence mortality and prevalence data for each tumour type. So I've just pulled out a few examples of the type of analysis we pulled out as part of that PAM Vanguard work, and actually some of the value of pulling it out on a wider scale than just West London. So firstly, cancer waiting times, and I think this is something that is often missed potentially nationally because it's not published in this way, is this is performance over a year in West London. But what this looks at, rather than tumour type, which is widely looked at, this looks at what type of treatment a patient has for their first treatment. So I can tell you overall over this period, our own partners got about 84.5%, so just under the standard over the year. But what you can see here is if a patient only has palliative care, performance is 93%, hormones 89%, surgery, so majority of patients have surgery, actually 86%, active monitoring, which would mostly be prostate, about 87%, but then the oncology treatments, so chemotherapy at 79% and radiotherapy only at 56%. And actually else, because I've seen this for the rest of London, elsewhere in London, that radiotherapy figure in one area is in the 30s, so it's clearly a national issue rather than just a local issue within our area. This is one example of why looking at several alliances rather than just ourselves is useful. So this is head and neck 6TA performance over a year period. So it isn't the area where we perform the lowest in our partners in terms of head and neck. What you can see here is elsewhere in London also struggles. So there isn't somewhere else in London where you'd go and look at. But Greater Manchester, so the other area, the Vanguard, is actually achieving a 6TA standard for head and neck, and they have done on a long-term basis when you look back over their data. So there's clearly something there they're doing differently and might be an area to learn from. This is just one example of looking at variation treatments. So what this shows is minimal access surgery rates for colorectal cancer for the 19 alliances nationally. And the dark blue bar is West London. So up actually you can see just below the England average. I suppose it highlights a few things. Firstly, nationally there is variation from 71% to only 25%. Also shows obviously there are areas doing better than us or higher than us in that area. One thing I would say is I've got this data obviously by SDP, CCG and provider. We have got some variation across our patch. So actually in northwest London, that percentage is over 60%. In southwest, it's less than 40%. So we have got some variation locally in that measure. And the last example, the PAM Vanguard metrics I've just pulled out, is obviously put into context of how we sit in terms of outcome measures for cancer. So as Nicola's already said, we've got the best 1-year survival in the country. This shows cancer mortality, which is actually age standardised, so it's accounted for the fact London has a younger population, but you can see West London has the lowest cancer mortality in the country as well. So the next area, I'm just going to briefly go over the national replication of the work we've done. Obviously, we've demonstrated that you can do this across 4 alliances rather than 1. So there's no reason why it can't be done for all 19 nationally once rather than for 4. So just say nationally, the National Cancer Programme's now set up CADIAS, which is the Cancer Alliance Data Evidence Analytics Service, which is a resource that's currently being set up with 15 analysts nationally to support cancer alliances. The key thing here, in addition to what we've done, is these analysts will be based in the cancer registry, so with access to PHE data. So we'll be able to actually access more data than we are locally currently. I just say how we're feeding into that work. Firstly, one of their early projects is to replicate the metrics we produced across the Vanguard. So as a starting point, that all alliances nationally have access to the same type of information. We've also, as a Vanguard, so the 3 Vanguard partners, put in a recommendation paper to the team about the type of analysis that would be useful for alliances. So the first one, as already mentioned, is creating a data pack for all alliances nationally rather than just the ones in the Vanguard. We've also put in a request that any work that's done nationally now includes a regional breakdown rather than the overall England rate without the regional breakdown. We've also made the point it's important to have the alliance structure support using that data. So all alliances nationally having that governance structure to actually use the data. And also, and it's probably a local need for us, because where we are is around starting to investigate the outliers locally. So a resource to use that PHE data to understand outliers. So moving on to how we've used that data locally. So the first thing is we've produced a local scorecard within our partners, which has primarily been to support our governance groups. The focus of that scorecard, rather than looking at individual provider and CCG performance, even though that is in the backing data, has been to look at the regional performance. So looking at how we do as a system. Alongside this, I think we've got to the stage now where Informatics is a standing agenda item on all those governance meetings. Admittedly, about half is usually cancer weights, but we also discuss other data items as and when they arise or get published. The way the data has also been used is obviously our priority pathway groups were initially selected using the data. So lung, colorectal and upper GI was based on which cancers caused the most deaths, whereas prostate was the impact on 62-day performance. And also to say the discussions within the pathway groups have been facilitated by having access to this data. And finally, I think with this resource and the expertise we've built up within our partners, it's been able to support things such as the transformation bids and also the projects going forward. Just so the way the scorecard was developed was based on the overall outcomes framework which the executive group agreed. So that's the key areas there. So best practice care, positive patient experience, best clinical outcomes, maximising quality of life and improving equity. So that was translated. This is the front page of the scorecard, the latest version. So just to go through the sections in there, obviously 62-day and 2-weight performance are on there. We've also got screening, and I think this is one area where what we've tried to do is put this in national context. So the last column on your right has ranking against other alliances, and the screening rates are quite telling, not only not meeting the standards, but we're either the second or worst alliance in the country compared to others. And just to give you an idea of how this type of information has been used in our governance groups, so the cervical screening rates were discussed at the clinical oversight group. So with the headline of saying we're the worst in the country and actually the rate's going down, which it isn't nationally, but so we've got an area where we're the worst and it's getting worse. So that resulted in our primary care projects and transformation fund setting up a project to look at improving that, which I believe is recruiting additional practice nurse resource to try and improve that and get more patients attending. The other areas on there, there's an area on endoscopy services weight, because that's been a particular area in our patch. Patient experience was based on NC pairs. Then clinical outcomes, proportion stage 1 and 2, emergency presentations, 1-year survival, and then quality of life, we're focusing on living with beyond cancer metrics. The 2 areas pulled out at the moment are holistic needs assessment around diagnosis and end of treatment summary, and then finally an area on data quality, because obviously it drives all the other metrics. Just to give you an example, which I think you've already seen today, but just to illustrate how the data is being used. So this is looking at how the low-dose lung CT pilots were selected, which I think Tom Newson and Dave already mentioned. So the first is, this is survival for North West London, for lung cancer, 1-year survival. So that red line at the bottom is Hillingdon. So you can see overall in North West London, survival in every CCG is above the England average, apart from in Hillingdon, where it's actually below the England average and actually a negative outlier when you look at it nationally. So clearly a particular issue in Hillingdon around survival. And then Hammersmith and Fulham, for a slightly different reason it was selected, which is looking at the incidence and mortality rates. So overall, North West and South West London have low incidence and mortality of lung cancer, apart from in Hammersmith and Fulham. And obviously the 2 are quite closely linked, and then you'd link that to smoking prevalence. But it's just a way we've used that data to drive down to where the best places are to roll out such pilots. And just briefly to go over what support is offered locally to providers or CTGs in West London. So firstly, if people don't already have access to that cloud, they just need to drop us an email and we can give you access to that cloud. We've also been doing some work with trusts around delivering cancer waiting times. So as well as that data analysis, we're also able to provide advice on processes within trusts. We're also able, as an alliance, to have those discussions nationally with organisations. So we actually sit on quite a lot of national boards now around deciding that. So particularly around the National Cancer Programme, but also discussions within Public Health England with the Cancer Registry. And the last one there, ad hoc support. So if a trust had a particular query around numbers of cancers, something we're able to provide that. Admittedly, I'm hoping most of that is covered by the metrics we produce. So quite often a query will come in and I'll say, well, we've already done that, here's the data pack, which already has the data in. But we also do ad hoc requests as needed. In terms of just future developments coming up, obviously the first one is around obviously the CADIAS team being developed nationally, so we're inputting into that quite heavily. And a key thing to that is obviously if they do the work nationally, it will free up some of our resource to do other bits of analysis, so it's quite a key step. We're expecting some national publications at regional level, which hopefully will let us understand some of the variation we see locally, so survival by stage and also treatment rates. We're also working with PHE and CADIAS around understanding our survival outliers, because I think because our survival overall is quite good, we're to the stage of actually where is it not so good compared to the rest of West London. So those 3 areas are breast cancer in Croydon CCG, colorectal in Sutton CCG, and lung cancer in Hillingdon CCG. So interestingly, not all the same CCG for different cancers. We're also building on the collaboration with other cancer informatics teams in London. So I think there's been a lot of progress on this. There is now a London-wide steering group where all the analysts meet. But I think the next step is to look at how that work programme could potentially be shared around different organisations, because we've probably the best resourced region in the country in terms of cancer analysts. So we've got 13 posts, I believe. But they're all in different organisations, so it's trying to pull that together and reduce duplication. And obviously a big thing coming up over next year is cancer waiting times, but including the introduction of the 28-day standard and the data requirements around that. Thank you.